Welcome to the latest episode of CarePoints. I'm your host, Kenny Schiff, Chief Marketing Officer for Lone Star Communications, the Alero Solutions Group, and our latest family member, Promobix. Today's episode is part of my continuing series of conversations with my collaborators at Lone Star, customers, partners, and notable folks in the tech industry. Thanks for joining me today, and I look forward to another great conversation with my guest. Hey, everybody. Welcome to CarePoints. Today, I have as my guest Jeremy Guy from Willis Knighton. And I'm going to start by having Jeremy talk to us about Willis Knighton in general, and then talk to us a little bit about his background and how he got involved with fall prevention, fall prediction, and sensory technology and AI and all that good stuff. So welcome, Jeremy. Tell us a little bit about Willis Knighton.
Thanks for having me, Kenny. I appreciate it. Willis Knighton Health is a 5-campus regional health system in Shreveport, Louisiana. Where I specifically work, we have a campus that is dedicated toward rehabilitation, both physical and behavioral. My introduction to this world, it was clinical at first. I am by training a physical therapist and have been a physical therapist for 26 years and worked in multiple locations and multiple settings, from acute to outpatient to inpatient rehabilitation. So my original introduction to fall prevention had to do with the clinical perspective of preventing falls and treating patients who had falls and subsequent injuries. About 4 years ago, I moved into a leadership position in our physical medicine and rehabilitation department as the performance improvement and safety coordinator. And certainly part of my job as being over safety and quality for our department is to ensure that our patients stay safe and do not fall and do not, receive those injuries that can be so life-changing to them after a fall.
Do you have a personal reason why you are a falls sort of champion and why that's important to you?
I don't have a specific, family member or close relative or friend that had an experience with falls, but clinically, having treated patients over a 26-year period, I have seen over and over again how important it is to stay upright throughout our lives, to minimize the effects of falls. If you look at the data on falls, it is the single most preventable and most common preventable adverse event that happens to folks in healthcare and in the community. It's the leading cause of mortality other than automobile accidents in adults, specifically older adults. So we see the effects of falls day to day clinically in our outpatient facilities, in our inpatient facilities, and certainly in our inpatient rehab. So my focus has always been the patients that I deal with and how to best treat them, but just as importantly, how to prevent this from happening again.
So the whole falls mitigation, managing that, thinking about it from an organizational standpoint, it's a journey. Different people have different kinds of ideas about what to do. I'm sure that Willis Knighton explored many, many different things. Let's start talking about the sort of people side of this from a staff and team perspective. How did Willis Knighton go about building consensus and urgency around addressing falls?
Well, we analyze falls on a yearly basis, each campus, and in some cases, each unit, but certainly the world that I live in inpatient rehabilitation, we track many metrics related to the falls. We trend both our total falls for our inpatient rehab facility and our fall rate, because it's important for us, again, to limit the potential regression of our patients. Inpatient rehabilitation is all about moving forward, having our patients improve their mobility, improve their function so that they can go home and return to as many of those normal daily activities they can. So falls tend to set people back. And so we wanted to make sure that we're addressing every aspect. We've done this for a lot of years. We've been focused on falls for a lot of years. And one of the things that we really have tried to make a stress point for us is making sure that our analysis is multidisciplinary. We always involve the nursing managers or nursing boots on the ground employees that are seeing these patients and treating the patients, but we also include physical therapy, occupational therapy, all the different team members and all the different disciplines whose job it is to be a part of the solution for preventing falls.
Yeah, I what I'm hearing from you is that this is everybody's work together. In order to build consensus, you really needed to involve lots of disciplines, and maybe ones that you might not have originally thought about. Lots of people have to be involved with this. So, going back a little bit to when you started this journey that eventually ended up you leveraging the capabilities of Ocuvera to support you, what other things did you guys do beforehand before you decided to use some more contemporary AI-based technologies to support you?
Well, certainly over the years, how we have approached falls has morphed and changed. A couple of times we have dug deep into post-fall huddles, and we still utilize those to have different disciplines come together after a fall and to determine what the potential cause of the fall is and how we could have prevented it. Most of our previous forms of fall prevention included multiple ways to communicate between disciplines, but we never utilized any type of sitter, any type of video device, anything that would allow us to approach and address falls that occurred without our staff with the patient. We utilize risk assessment tools and to help kind of make sure our staff knew who was at risk, especially those that showed cognitive deficits or confusion. But that has been kind of a bugaboo for us and for a lot of facilities for a long time, is how to address those patients that you can't educate, that you can't get them to buy into why this particular part of your program is for their own safety. And that's what kind of led us down that road away from your standard fall prevention, tools, which again, we use a lot of those in conjunction with what we're using now, this AI-based prevention system. But it led us down this road to really address those. Those are the ones that scare us. Those falls where there is no patient, or excuse me, no staff member that is there to help ease the fall, or no staff members there to help control the fall. Those are the ones where patients get injured, and usually the potential for serious injury goes way up with those type of falls. So that's what we really wanted to reduce. And we had seen an increase in those type of falls at our inpatient rehab facility before we went to the current system we have.
How about more traditional supporting technologies like bed sensors and chair sensors and those kinds of things?
We still utilize those, but they've become an ancillary part of the system that we use. They can be great. They can be useful. But if you look at the data on bed sensors and chair sensors, it's not great in terms of showing a significant reduction in falls, because there are a lot of variables that you can't necessarily control. The physical layout of your unit may preclude a patient who is a fall risk being further away from the nurse's station. So the reaction time by a nurse to a bed alarm or a chair alarm you may not can increase that just because of the distance to the room. Sometimes the physical layout of a room itself, and you may not have any control over that, that may affect the safety and the response time. So there are while those tools are valuable and they can be a great part of a comprehensive fall prevention program, they can't be, or in my opinion, they can't be your basis.
But I think the key thing that you're saying here is this comprehensive program. So you're picking the components of it and also teaming it with the people involved, and that's how you're driving towards the outcomes you're looking for.
Absolutely. Every part of an effective fall prevention program has to be tailored. It can't be cookie cutter. We really pride ourselves on looking at each individual patient's needs, their risk, from every angle. And that's why we stress the multidiscipline aspect of our program. But you have to tailor it. If you do not, you are going to miss a variable that you did not think of or assess, which in turn is going to increase the risk of falls for that patient. Our facility is a stroke specialty program, accredited program by CARF. And so what we realized over time is we had a lot of neurological diagnostic patients, a lot of patients with cognitive deficits and confusion and poor decision making. So we had to tailor our program specific to that particular patient caseload in order to be as effective as possible at reducing those falls that do not have a staff, that occur without a staff member being present.
So Alero Solutions is part of Lone Star Communications. Lone Star has an ongoing relationship with Willis Knighton. So as we go forward in terms of the services we provide to customers, having the right kind of fall prediction prevention partner has been important to us, which is hence how we arrived at embedding Ocuvera into our active fall prevention product. So what we love about Ocuvera as a technology partner is how mature their product is at this point, and how based on evidence the work that they have done is. So I'm curious, from as a buyer or an influencer in the decision around Ocuvera, what stood out about Ocuvera's predictive sensor-based AI approach, and in general, what about their technology and how you would partner with them?
One of the things I really liked was the flexibility of the sensors and the program itself. There are multiple settings that you can utilize, again, to tailor the use of the system to the patient's needs. So there is a predictive analytics setting where if you have a patient who you're really concerned about them getting up in the middle of the night and trying to go to the restroom because of confusion, you can set them on predictive, which allows that system to then alert the nurses at the nurse's station when the patient begins the process of getting up out of the bed. It analyzes those moves and predicts they're about to get out of bed or out of chair. But then one of the other concerns that we had is alarm fatigue. And so if you have a patient that moves a lot, but isn't necessarily a large risk to get out of the bed, you can change that setting to an exits only setting where you're only alerted when the patient actually leaves the bed or leaves the chair. There's a video only setting that you can utilize where you can check in on patients maybe that are on some type of precautions like contact or droplet, where you can check on the patient but not have to go through the entire process of putting on PPE every time you go in the room. You can remotely check and see if they have, proactively check on that patient and see what they need. So I like the flexibility of the different settings. And then one of the other things that certainly drew me to them once it was presented to me was the fact that Ocuvera was so willing to listen to our needs specific to our facility. It's been a good partnership. We've been able to really fine tune the product to what our needs were for our facility.
So as you were going through the decision-making process of determining that this would fit into your program, what were your evaluation criteria? And I know that you kind of started initially, as many people do, in a pilot mode. So tell us a little bit about how you thought about it as you were leading up to bringing it in, and what that process was like, and what led you to a go decision, if you will.
Well, I wasn't really part of the decision to bring it in, to be honest with you. When the decision was made to trial this, I was still actually a clinician treating patients. So, and then I came over as we were moving to that. But yes, we did go through a 2-year trial basis where we analyzed the data for our falls and all the different metrics that we look at before we determined that we were going to continue with the product. But in terms of me being the decision maker, I was just a pawn following what my boss said. So I hate to be blunt about it, but that's the truth. So.
Oh, and it's not uncommon, but you're a champion at this point. So clearly the decision-making process, there were things about it that obviously worked.
Absolutely. And we saw immediately the first year that we trialed, there was some kind of stagnation in terms of our metrics and numbers, as we were establishing trust in the system by our staff, as we were getting buy-in. And then the second year of the trial, we saw a reduction in falls. And I will say in that first year where I say there's some stagnation, what we did see is a 20% reduction in unobserved or unassisted falls, which was, as I've stated before, is very important to us because those are the patients that tend to get significantly injured. So that immediately jumped out to me is that reduction in those unassisted and unobserved falls. Then last year we had about a 9 or 10% reduction in falls and fall rate. This year, if things don't change between now and the end of the year, we're looking at about a 35% reduction in our total fall number, and somewhere around that number for the fall rate reduction, which, we couldn't ask for anything better.
Oh yeah, and it's sustained. A lot of times there's a lot of excitement about a new technology, and there's a lot of attention to it, which sort of potentially skews what you might think of the longer term impact is. But the fact that you're now mature in terms of your program, the sustained results are really great. So since you were involved, maybe not so much in the initial decision making, but you were involved in implementation and rollout and all that kind of stuff. What were the challenges that you guys experienced along the way? Just imagining somebody else watching this who's considering doing this, what can they expect?
Well, certainly staff buy-in whenever you're introducing something else that's going to have an alarm attached to it can be difficult. So it was imperative that we were able to show the value of the system. One of the other things that I think was important for us is we took their concerns, the staff's concerns, when we were educating them about the system, and used those concerns as a point of reference whenever we would re-educate, whenever we would introduce different aspects of the system, make tweaks to the system, because we developed our own standard operating procedure for this system within the confines of what we want to be as a facility. Want to be a reliable organization facility, but specifically for our rehab facility, we have standards of excellence that we want to meet. So it was easy for us to take those concerns and relate them to the standards back to the staff. Certainly there is nothing that creates buy-in like personal experience. And we were fortunate, I guess you could say unfortunate and fortunate very early on that, and I remember this distinctly, we had a scenario where we had a patient who fit all the criteria: neurological diagnosis, confusion, wanted to go to the restroom, had no business trying to get up out of their wheelchair at the bedside and going to the restroom. And we had a scenario where that patient attempted to do that. The nursing staff was stimulated by the predictive alert to get into the room in a timely fashion, to get in there quicker than they would have been if they would have been even stimulated to do so in any other way, and save that patient from potential injury by stopping a fall. And we could show the video. We could bring our staff in and say, look, this is what this system can do for you. It can get you to the room when you wouldn't be stimulated to do it otherwise. It can get you to the room faster than you ever would have before. So that has certainly helped. One of the things that I track with the system on a day-to-day basis is potential prevented falls. And there wasn't really a way to track that other than during the falls that may occur with our staff member, hands-on, those patients, what we call near misses. But I think in the first year we had somewhere around 365 potential prevented falls using the system, where a patient got out of bed or got out of the chair. The system stimulated our staff, and our staff entered the room within 10 to 12 seconds. So it was a wonderful visual cue for our staff about the value of this system. And that's what it boils down to. And certainly alarm fatigue, it's been talked about, it's been written about, it's been researched throughout healthcare, in multiple ways and from multiple perspectives. But again, to refer back to this particular system, the fact that I can adjust the setting and minimize the potential of alarm fatigue with patients is huge for us in terms of creating the buy-in from our staff.
So you have a reputation, Jeremy, as being a data guy.
It's true. It is most definitely true.
So, and what's cool is listen, you're a physical therapist. You're somebody who's going to have hands-on with patients. So that combination really kind of makes you be a bit of a Renaissance guy, right? A
Right.
little science, little healing art, kind of all those things go together. So you talked a little bit about it already, but let's just kind of reinforce that and call that out a little more. So how are you tracking and measuring the impact of this program in general? Like, what are the things?
Well, every day I review every alert that has been stimulated by the system, both for the content, but also the type of alert. Is it a bed exit? Is it a chair exit? Is it a predictive alert that was meant to stimulate our staff to go into the room and enter the room and maybe prevent a fall? So I look at all the different alerts. I classify the alerts, whether it was a patient, a staff member. I classify if I think that the alert itself was a false alarm, and I make notations about what that false alarm might be, because that, when I have monthly meetings with Ocuvera to discuss how the system was working, I can share that data with them and let them know, here's where we're seeing issues. Here's where we're actually getting some false alerts or false alarms. They've been wonderful to be able to take that information and create solutions for that particular problem, because again, that's another factor that can lead to alarm fatigue. And then I relate, when we do have falls, I relate back to all the specific metrics that are important to us, that are metrics that are industry standards, but also important to us, like medications. And, if the patient had taken a medication within 2 hours, does that medication have an hallucinogenic or a neurogenic property to it that would cause a potential problem? I like to track the activity. We tend to see greater than 50% of our falls happen when patients are in or going to the restroom, and that's nothing unique for our facility. So there's a lot of different metrics that we track specific to a fall itself. But in terms of the system, for me, it's all about analyzing the alerts, making sure that the system is performing the way we want to, sharing that information with Ocuvera so that we can make the adjustments to make sure that it is as effective as we want it to be.
So you just gave all the good data points that you're going to be looking at from a standpoint of the system or the program in general performing. What about staff? How are you measuring how they're feeling about this, and also and just responsiveness in general? Because from what I'm hearing from you and I've observed myself, it's a combination of the technology and the people. Mm-hmm. So how are you looking at that?
Well, certainly informally, my office is right down the hallway from the inpatient rehab facility. So on a weekly or monthly basis, I'm walking around the facility, gathering information from our nursing staff, from our therapy staff about their thoughts of the system and how the system is working for them. Our team has really bought into communicating back to me if they see issues with the system or if they have concerns about it. But I did this yesterday, just as a normal part of my routine to go ask our nurses who are dealing with it on a day-to-day basis, their thoughts of the system. And it's been overwhelmingly positive. Like we said, initially the skepticism about adding more alarms in has been quelled by the fact that our leadership team has taken the time to seek out that feedback from the staff that's treating the patients. It's one of my goals coming up in the next year is to allow the staff to provide anonymous feedback. My concern is maybe they're just going to be nice to me because this system is part of what I do. It's part of my job. Maybe they even see it a little bit as my baby at this point, but I want to reach out to them and allow them to anonymously provide feedback about the system and with the hopes of ensuring that everything we're getting from them is absolutely honest and 100% what we need to make the system work for us as best as possible.
So one of my missions in terms of doing this kind of work and talking to people like yourself is to educate others who are considering going through the journey, may have had some things that were unsuccessful for them. They're exploring other options. So let's do a little summary here and say, what were the key factors in making the program be successful?
Certainly communication. once you find a program that you like, once we bring it in, once we trial it, making sure that our staff members understand that they have the ability to help us maximize the potential of the product, and that feedback helps drive certainly buy-in and utilization of the product by our staff. If we're not using it right, it's not going to do us any good. And so we've got to make sure our folks that are boots on the ground, that are treating patients, are all in on the system itself. The other thing I think that's very important is tailoring your use to your needs. Our particular facility, like I said, has a very high neurological caseload. So we had to make sure that our standard operating procedure and utilization of the system fit our needs and fit the needs of the patients themselves as best as possible. If we don't do that, then we're not maximizing the potential of the system.
Great. So any surprises or unexpected learnings along the way?
One thing that I thought might be a problem, but wasn't sure that it would be, and I guess problem's too strong of a word, but something that we had to address is the general public's fear of AI and the fear of technology. On multiple occasions, I've had to go in and explain to the patient or a family member that this is not a video feed that's going out on YouTube or into the ether for public consumption. And more importantly, that this is not some type of technology that will be used in a punitive way toward them or toward the staff. So, we could maybe see that, as a potential hurdle to climb over when we were setting them up, but it has continued to be real. I think the more that we've dealt with it, more skilled we've become in explaining it in a way to patients that they understand the benefit, as opposed to feeling that fear and that anxiety about the system itself.
Yeah, I think it's important for people to realize that this is not a surveillance system.
Right.
Some of the technologies may come out of that world, but it's not, and it's not about invading people's privacy, right? So, but the technology is capable of providing a level of assistance and support because of how accurate and specific it can be and how tuned it is. And for me, as I've learned about the Ocuvera's underlying technology, that's the beautiful thing about it, is that it's not just a camera watching people that is being repurposed for this. It is purpose built.
Absolutely. Absolutely. And, we've utilized it with, some ancillary benefits in mind. When we do have a fall, let's say that occurs with a staff member, I'm able to go in and analyze that fall, see if it was preventable. And that may lead me to specific education to that staff member on how to more safely transfer a patient out of bed to chair. So I think it's been from an ancillary perspective, it's been a great tool for us to drill down and be specific with our education on a staff member level, as opposed to global education, which we all do, but sometimes doesn't hit home for particular staff members.
It's great, the work that you have done. I have to imagine, learning about you, that you have lots of ideas about where you're going next, and the folks you work with similarly. So what's next for fall prevention at Willis Knighton?
Well, certainly we're going to continue to utilize the Ocuvera system, the AI-based predictive analytics system to be able to drill down with our fall analysis. Hopefully we're going to continue to expand the utilization of this information to feed our education of our staff, to make sure that they are receiving everything they need, both in the onboarding perspective and certainly after they're here and working, to be as successful as possible about keeping the patient safe. I certainly want to expand, our acquisition of their feedback and their thoughts on the system. But more than anything else, I think we would just want to continue to be diligent and continue to be as comprehensive as possible about our analysis of our falls and utilizing every possible avenue to keep our patients safe.
And because of the sustained success that you've had, it's got to give you some level of confidence about what you can do next. And I think that so many people have been working hard at the falls thing for so long, and in many cases, not as effective as they would like to be. Yours is a great story to tell. It's not like you're this enormously, ridiculously large, massive institution. Yet you are using this combination of intentional, thoughtful leadership combined with some good practices about working with patients and assistive technology. It's a great story to tell. Let's leave you with one last question and address my audience who may be peers like yourself who are looking at doing these things. What advice would you give to other health systems considering a similar journey?
I would suggest to them that they begin with analyzing from within, seeing what their type of caseload is, making sure that, with all the options out there at this point, that you find the right tool for your caseload, for your specific needs, for your staff, for your region, and, all the different, factors that may be a part of falls in your particular region, because certainly there are aspects that you have to consider with that. But more than anything else, seek out a system, seek out a program that is multidisciplinary, that is as wide ranging as it possibly can be, but that has the ability for you to be able to drill down and really work hard on how to best keep your individual patients safe by looking at their individual needs.
Yeah, in many respects, all those of us who are on the technology providers, service providers, we offer magic to people. We get people excited about the magic, but in the end, there's hard work involved, and it's typically, in as much as the technology helps, it's not the thing. It's only part of the thing.
Absolutely.
Anything else you want to leave my audience with, or parting thoughts?
I think we have covered it all at this point. So I'm so excited and thankful for the opportunity to be here and talk to you today, Kenny, and to really, expound upon something that's a passion project of mine, and has really grown over the last 4 years of being involved in this process.
Well, thanks. It was a great conversation, and I appreciate very much your willingness to share what you've experienced, and I'm sure it'll be helpful to the folks that are listening and watching. Cool. Thank you. Thanks so much for joining us today on CarePoints. I encourage you to hit the like button and subscribe so that you can get notified when we release our next episodes. Make sure to subscribe on your favorite podcasting service, Apple, Spotify, iHeartRadio, whatever your favorite platform is. And make sure to visit us on the web at www.lonestarcom.com/podcast. That's www.lonestarcom.com/podcast. You'll find all of our old episodes there. Thanks so much for listening, and looking forward to having you back soon.